Welcome to the latest edition of the College of American Pathologists Capcast. I'm Becca Battisfor, Content Specialist with the CAP. In this episode, our guest host, Dr. Gladell Paner, will be talking with experts about how the cancer protocols support pathologists in reporting skin cancer diagnoses. Approximately 9,500 people in the U.S. are diagnosed with skin cancer every day, according to the American Academy of Dermatology. Melanoma is the most serious type of skin cancer. In 2024 alone, the American Cancer Society estimates that more than 200,000 cases of melanoma will be diagnosed, as well as nearly 8,300 deaths from melanoma. Before we get into the questions, let's learn more about our guests. Dr. Paner, would you like to introduce yourself?
Yes, I will. Thank you, Becca. So good afternoon, everyone, and thank you for tuning in to Capcast. I'm Gladell Paner. I'm a geopathologist at the University of Chicago. And for the past 7 years, I had the opportunity to work with the CAP Cancer Committee and also with the CAP Pathology Electronic Reporting Committee, or the PERT Committee. As of now, besides doing the CAPcast, I'm also involved in creating two products for CAP through the Council of Education. The first one is the CAP Gleason Grading Course. This is an educational online course, and the second is the CAP Prostate Cancer Flip Classroom webinar. And we are scheduling this exciting products to be released at the end of this year and at the beginning of next year. So watch out for these products.
Great. And Dr. Shon?
Hello, everyone. My name is Wonwoo Shon. I'm a pathologist at Cedars-Sinai Medical Center in LA, California, where I serve as the director for the dermatopathology service and fellowship program. In the past 6 years, I also had a pleasure of working with the CAP Cancer Committee, and thank you for having me today.
Thank you for being here. And Dr. Kinonen?
Hello, my name is Chris Kinonen. I'm a dermatopathologist in private practice in Madison, Wisconsin. I've been practicing about 11 years. I'm actually one of 4 dermatopathologists in our practice. So I'm fortunate to have some expert colleagues next to me. We work primarily for a large healthcare system that serves Madison as well as a number of other hospitals and clinics in rural and urban Wisconsin. And we serve fairly robust dermatology practices as well as a number of primary care physicians and surgeons who send skin biopsies.
Great. Thank you all for joining the podcast. Dr. Paner, I'll let you take it from here.
Thank you, Becca. So for this Capcast, we're going to talk about the melanoma resection and biopsy protocols. And I would like to start my question for you, Dr. Shon. So CAP released this very new protocols. I think they were released in December of last year, so very fresh. So my question for you is that, can you tell us why these protocols were created? And second is, can you also describe to us the process in creating these melanoma protocols?
Similar to other CAP cancer protocols, we developed a melanoma protocol to help practicing pathologists provide clear and easily recognizable diagnosis and core data elements for clinical care. As you know, a synoptic format definitely enhances the consistency of reporting data elements. Although our melanoma biopsy protocol is currently optional, it is highly recommended for melanoma reporting, as the core elements are only present in the initial skin biopsy specimen, as you know. I have to admit that creating a protocol is a pretty intense process. Like other CAP templates, we start by referencing the gold standard, including key parameters for AJCC staging and WHO tumor classification terminology. The process actually starts with a cancer committee member who drafts the initial version, which is then reviewed by a team of expert authors. Many are members of the AJCC panel or WHO authors. And then the initial draft is reviewed by the House of Delegates. We then meet to discuss the protocol, consider changes, and gather some feedbacks. And this feedback is incorporated, but really ensuring still alignment with the gold standards I just mentioned. The final version undergoes another pretty rigorous QA process, I'll say. And I really want to emphasize that the cancer committee really ensures the protocol is applicable in various clinical settings, not just in academic environments, but also in community-based practices. Again, it is very important to note that these cancer protocols are not for research purposes. All included core required parameters are clinically relevant and actionable.
Thank you, Dr. Shon. I like your explanation, and I agree with you that this is really a rigorous process. And of course, the goal is to have the optimal product that we can provide to the pathologist. And to kind of highlight one point that you made there, the review process done by the HOD, and this is very important, and also the public review. And this is the reason for this is, of course, so we will have input to the creation of the protocols, not only from experts, but also coming from the community practitioners. And we try to emphasize also the practicality of this protocols, when we're using it. And just to raise a point there, you said that the excision protocol is the one that is required at this point.
Yes.
Okay. And the biopsy is only
optional
at this point. Thank you. Now, I'd like to ask you, Dr. Kinonen, and I'm sure you're probably using this protocol. It's fairly new, came out December, so I'm not sure if you have this already in practice. But asking you from the user's perspective, as a pathologist at the other end, what benefit do you see in having melanoma reporting protocols in your practice?
Yeah, we definitely use the protocols, and I would agree with Dr. Shon that most of the time, all the material required to complete the protocols is usually in the biopsy. So we use it for the biopsies. It's almost exclusively where most of the parameters are found. So I think the protocols really help create standardized terminology. So we're all using the same language, which I think help better align to clinical guidelines such as NCCN guidelines. I think it helps create more consistent reporting. So everyone, the pathologist, the oncologist, the surgeon, that we're all on the same page. I think it also helps us to ensure we've kind of dotted all our I's and crossed all our T's and kind of just remember to put all the required elements in a diagnosis. Cancer diagnoses have in many ways become more complex, and I think the protocols really help us ensure that we've included all the necessary components in the diagnosis. And overall, I think the intent of all this is that it will lead to consistently higher quality diagnoses with improved quality of care and increased patient safety.
I like to emphasize what you said earlier about the use of these protocols. It's important for us to harmonize our protocols, the pathologist protocols, with the clinical guidelines terminology. And I think the success of the clinical guidelines also rely on the pathology reporting protocols, because those parameters or those factors, pathology factors, are being asked in the clinical guidelines should be there, right? Consistently being reported in this pathology protocol. So you made a very good point there.
Yeah.
I want to go back to you, Dr. Shon. The WHO classification of skin tumors was also released last year, so fairly new. So about the melanoma histologic subtypes, we know that it's further refined in this new WHO classification. So can you briefly describe the histologic subtyping of melanoma and how sun exposure matters, and why these tumors are categorized into pathways? I'm asking you also as a geopathologist. I saw this Roman numbers 1 to 9, something like that. So can you please explain to us what this means?
Yeah, sure. So, I mean, first of all, when I was a trainee, the cutaneous melanomas were primarily classified by their histopathologic growth pattern. However, based on the current epidemiological and molecular evidence, the new WHO classification proposes a multi-dimensional approach considering the role of UV radiation, cell origin, and characteristic genomic alteration. This new classification really, as you mentioned, identifies 9 distinct pathways for melanoma, with sun exposure being one of the key determinants of tumor subtype. For instance, first 3 pathways are linked to UV radiation as the primary mutagen, while 6 others have no clear relation to UV radiation. This multi-dimensional pathway-based classification of melanoma clearly demonstrates that I'll say cutaneous melanoma is not a single disease, but a collection of distinct subtypes, each differing in genetic features, clinical and histopathologic presentation, age of onset, preferred anatomic site, and cell of origin. However, just like other tumors, this classification is not perfect and still evolving relatively fast pace. So that's why we just keep updating our protocol.
Thank you, Dr. Shon. So there's a lot of differential diagnosis here, if you will. So this is a question for you, Dr. Kinonen. So in your practice with this histologic subtyping of melanoma, which among these subtypes or other types that are not listed here, which among these are difficult to diagnose, difficult or challenging for you to diagnose? And can you tell us or share us some of the pitfalls in making the diagnosis?
I think the main hurdle is first getting to the diagnosis of invasive melanoma, regardless of the subtype. And sometimes that's very straightforward and sometimes it's very challenging. I think once you get to that, you're definitely in the invasive melanoma category, then subtyping it, most of the time, I think that fits into a small number of these subtypes. I think for the most, at least in my practice, most of what we see is in the low cumulative sun damage category or high cumulative sun damage category, the lenticular maligna or superficial spreading melanomas, nodular melanomas, to a certain degree, desmoplastic melanomas similarly. I think most of the time, it's usually pretty easy to put them into a category. There is some subjectivity. For example, the difference between low cumulative sun damage and high cumulative sun damage subclassification is somewhat subjective. There's some, information about sort of the size of the solar elastotic aggregates, and as being large amorphous aggregates versus kind of fine single fibers that can help differentiate those two. But there's going to be a spectrum, and where you draw that cutoff may be somewhat subjective. The difficult ones, I would say, desmoplastic melanomas are always kind of a treacherous pitfall, especially if you're getting a superficial biopsy, and it can be a subtle kind of bland looking infiltrate. That's always one to be on the lookout for. Similarly, nevoid melanomas are one of those treacherous diagnoses that at low power looks, very much like a nevus, and you have to really study at high power to get it right. There's rare ones like Spitz melanomas, where I, maybe once or twice in my career I made that diagnosis. That would be, even as a dermatopathologist, one that I would probably get, sort of expert melanocytic consultation on myself. So I think that one can be very difficult. And then there's these subtypes of melanoma arising within giant congenital nevus and melanoma arising in blue nevus. I guess I would say more broadly, melanoma arising within any nevus can sometimes be difficult. It can be the case where there's obvious biphasic proliferation, where there's an obvious melanoma and kind of an obvious bland looking nevus that it may have arisen in. But sometimes this differentiation can be quite hard, and it's hard to tell if it's MIS arising in a nevus or if it's invasive melanoma. So anytime there's an associated nevus, I feel like that can present challenges.
Thank you, Dr. Kinonen. So the way I understand is that the difficulty really is not only in the subtyping, but from the first glance of differential diagnosis between dysplasia to melanoma invasive or non-invasive, and then subtyping. So there's several layers there of challenges. So subtyping is only one of those. That's the way I understand it.
I think so, yeah.
Dr. Shon, I'd like to loop the same question for you. In your opinion, in your practice, which of these subtypes or which scenario will be the most challenging for you?
I mean, I completely agree with Dr. Kinonen that there are some tumors that even experts cannot morphologically categorize definitively, and those cases sometimes require additional molecular workup, such as utilizing NGS platform. I think that things will improve as we learn more about these tumors using as I've just mentioned, using more advanced but accessible tools. Like for example, like the BRAF testing BRAF when I was trainee was very difficult. We need PCR or additional molecular testing, but now we have a very nice immunohistochemistry, very nice surrogate marker to just quickly check the BRAF status. That in that case we can vast majority of cases is just spits, non-spits kind of category. We can easily test it. Although there's a small subset of spits or lesions can be positive for BRAF immunohistochemistry. So again, just like other tumors, it's very hard to just definitely categorize it. Desmoplastic melanoma is the one subtype can be very difficult and sometimes it's relevant in further clinical care. For example, desmoplastic melanoma is somewhat prognostically favorable among those like thick melanomas and definitely affects, at least in our practice, affects the recommendation of a sentinel lymph node biopsy, which is generally, if you call pure desmoplastic melanoma, surgeons generally not recommended for additional sentinel, lymph node procedure. Also, some of the unusual melanoma, classifying, some of unusual types of melanoma, such as a spitzoid or spitz melanoma of a childhood, or I also agree the blue nevus associated melanomas. Those are actually clinically important in some situations because the standard prognostic models sometimes just do not apply to those somewhat rare subtypes.
I agree with that, and that's really heightened the challenge, right? If distinction between these two entities are clinically actionable, or it matters, and we have to make the call, right? I'm just curious, being a geopathologist, for our carcinoma subtyping, we use a lot of immunohistochemical stains. This is a question for both of you. Are you guys using immunostains for subtyping melanoma?
I say sometimes with the desmoplastic melanoma consideration, sometimes a MART and either SOX10 or S100 can be helpful. Desmoplastic melanoma should be staining with SOX10 and S100 and not always with MART1. So sometimes that can be helpful. Otherwise, with the subtyping, there's debate whether getting things like P16 can help in spitzoid tumors, and PRAME is used a little bit more often now, but that's more to get to a diagnosis of melanoma potentially rather than a subtype of melanoma. Probably IHC doesn't play a big role in the subtyping for me.
So it's just morphology. Okay.
I mean, so there are actually different pathways, and I'm not talking about just melanoma, but when we decide to, especially when I sign up with cases with my trainees, that before we decide to which pathway we're gonna go, sometimes I use a BRAF because some of the pathway, the very first initiative driver mutation is the BRAF V600E mutation. So sometimes I use a VE1 to which pathway we are dealing with. BAP1 or the other Win pathway markers such as the beta-catenin, cyclin D1, sometimes helpful to narrow down to deep penetrating nevus pathway. So I mean there are some so-called surrogate immunohistochemical marker for underlying genetic aberration. But again, as Dr. Kinonen mentioned, that first thing first, right? We have to make is this benign or malignant? Because that's actually most important, right? So
yeah, exactly. Thank you. So now let's dig deep into the contents of the melanoma protocols. So there are several elements that are listed, and among them is the primary tumor thickness and anatomic levels. So this is a question for you, Dr. Shon. Can you explain to us the importance of Breslow thickness and Clark levels and how these elements are derived?
I'd like to start with the Clark level, which are defined based on microanatomic compartments such as papillary dermis, reticulodermis, or subcutis. Although Clark level remains pretty good independent predictor of outcome, I have to say the inter-observer reproducibility for assigning Clark levels is relatively poor among pathologists/dermatopathologists. For this reason, it is not used in the current AJCC staging system for PT status, and it is included in our current melanoma protocol as an optional data item. In contrast, breast lobe thickness measure vertically from the top of the epidermal granule cell layer to the deepest invasive melanoma cell is the most important parameter for prognosis and a key element for the current AJCC staging. It should be measured in millimeters and recorded to the precision of a single digit after the decimal, such as the nearest 0.1 millimeter. There's absolutely no need to record a numerical value beyond the single digit after the decimal.
And I assume you must use a micrometer to measure?
Yes.
All right. And this is a question for you, Dr. Kinonen. So from your experience, what are the challenges in deriving the breast lobe thickness and Clark levels? And do you have any concern for the reproducibility? And how do you handle tumors that are transected at the deep margin or those tumors with ulceration?
Well, first of all, I would mirror Dr. Shon's comments about the Clark level. It is not always as straightforward as breast lobe thickness, and there's less reproducibility, as I understand, between pathologists in picking a category. I noticed that it was not a required element and tried not including it one time, and I got a call almost immediately from the clinician who wanted to put it in there. So I've since then just included it all the time, even though it's not a required element. And that just do your best to make the estimate. And that's all I can say is I just do my best to make the estimate. The breast lobe thickness is, I think, more straightforward, as Dr. Shon said. It's from the the top of the granular to the deepest area of invasion, or the base of the ulcer to the deepest area of invasion. This is similar to the comment earlier that I think the first step is to kind of make that diagnosis of invasive melanoma, and I think that's like such a critical step. And I think this is the next most critical step, is like getting the breast lobe depth right, because as Dr. Shon said, it's such a critical component to the next steps in patient management, that getting this right is really important. If you didn't subtype it correctly, it probably will have, may not have much clinical impact, but if you don't get the breast lobe thickness correct, it could have a big clinical impact. So what are the challenges? Finding the deepest area, I would measure multiple areas. If I have deeper levels available to me, I would take a look at several different slides to make sure I'm actually getting the deepest level present, particularly if I'm near a staging cutoff. It can be difficult, as I talked about earlier, when there's nevus also present. It can be sometimes difficult to determine exactly where the melanoma starts and stops relative to the nevus. That can present a challenge. Excluding adnexal involvement can be a challenge. Melanoma can sometimes extensively involve adnexal structures, and if there are hair follicles or eccrine glands or whatever that are involved by melanoma, on one level it could look like there's a dermal component. If you cut deeper into it, you would see that that is actually part of an adnexal structure, that melanoma. So making sure you're excluding involvement from adnexal structures can be one of the challenges. Similarly, you're not supposed to measure to microsatellites. Not supposed to measure the perineural invasion. You're not supposed to measure the lymphovascular invasion. It's really just supposed to be making sure you identify those areas of true dermal invasion. Another challenge is inflammation. Dense inflammation can sometimes mask dermal melanocytes, so sometimes IHC can be helpful there to see if there's melanocytes kind of lurking within a densely inflamed area. And then the last thing I would just say is just the mechanics itself of measuring with a micrometer. This is where it's so worthwhile to just check and double check and triple check, make sure you're on the right, using the right objective, that you have the measurement right. This is one of those, double checks just to make sure it's right. And it's an area where if I'm close to a staging cutoff, I'll get a consultation from one of my colleagues just to make sure it's, it's correct. So it's really worth spending time to do this. And for the other question about what I do with melanomas are transected, I just report that it is transected. I report that the depth will go to at least whatever level. And so it's stages at least whatever that corresponds to, and just note that it's transected at the base. And most of the time in our practice, that results in an additional excision to kind of be more definitive about staging before they do a subsequent therapy decisions. But it sort of depends on the clinical situation.
And just to clarify, the same measurement will be used for the staging itself, right? For the T categories.
Correct, yes.
Or A and B. Okay. So I'd like to move to another element here, which is the mitotic count. And I read that there's really a long discussion about mitosis for the melanoma protocol. So this is a question for you, Dr. Shon. The mitotic count, we know it's important in the prognosis of melanoma. So what is the recommended approach in enumerating mitosis?
Tumor mitotic rate is measured. First of all, it should be reported as the number of mitoses per square millimeter of tissue, specifically including only the invasive dermal component of the tumor. So you don't count the in situ. The count should start in an area known as the hotspot, where mitosis occur more frequently. Personally, measuring mitotic rate remains a very valuable data item for refining melanoma prognostic models. But I have to admit that at this point, I'm not entirely sure whether it should be absolutely required in the cancer protocol, especially since as of today, it is no longer necessary for AGCC staging purposes. It used to be, but not current edition. So I guess like this is actually one item I'd like to actually discuss with our current author panel. As you know, currently it is still a core require parameters to report in both the CAP and ICCR melanoma templates.
It's very interesting. So this is no longer included in the AJCCT categories. And
No.
before it was included. Okay, that's interesting, because as in my field too, the criteria is evolving, parameters are evolving, especially for staging. And just to recap what you said, so the counting should be in the invasive component. You should find a hotspot, and then in that hotspot, that's where you're going to focus, and then you have to count it. I think the new WHO is using the millimeter squared. I think this is kind of common now for all tumors instead of the high power field. And I like to look this question to you, Dr. Kinonen, since this is kind of something that is kind of a borderline right now. This mitotic count, it is important, not important. Should we take it off the protocol? So what do you think about mitosis? How far? What's the weight of this in terms of pathologic factors, in terms of your practice and experience?
Yeah, I think, well, Dr. Shon's point is, I think, very appropriate in that if it's not really part of the staging anymore, necessarily part of clinical decision making, that maybe there is some question about whether we should include this. This is one of the things we can spend a lot of time looking for is our mitotic figures, and if it's not clinically impactful, maybe there isn't a role for it. I have, in conversations with clinicians, I've gotten the impression that it's at least a curiosity for them, even if it may not impact their decision making. They're like, "Oh, honey, how many mitoses are there? Oh, wow, there's 7." That sounds like a lot to them versus there's 0 or 1 or so. I suspect that it probably is a curiosity and an interest to a lot of clinicians who have been seeing it for a lot of years, even though it may not, strictly speaking, be directly relevant to management.
That's a very good point. And I think this is one of those elements. I think, Dr. Shon, we have an experience of some elements like this in the GEO protocols. And actually, we brought that question to the HOD, something like sort of a survey, if the pathologists want to keep it or not. I'm sure, many probably would like to keep it off, the protocols as a required element.
It does help me sometimes when I'm, when the diagnosis of melanoma is hard. If I am finding dermal mitoses, that is one thing that can influence the initial diagnosis of invasive melanoma. So there's no absolute quantitative cutoff, but if I see 1, it's going to be different from if I find 10, So it does have a diagnostic role, I think, in identifying dermal mitotic figures, even if it doesn't, strictly speaking, impact staging.
That's a very good point. Another element here which is required is microsatellite lesions. So this is a question for you, Dr. Kinonen. So what is the importance of microsatellite lesions and their importance in the management? I think this is important for treatment of melanoma. And what are the criteria or challenges in their identification?
Yeah, so it does impact management quite significantly if you find microsatellite lesions. It will change the end stage. Even in the absence of metastatic disease within a lymph node, it will change the N category to at least N1C or N2C or N3C. And that changes the clinical stage to stage 3, which does make the patient, I believe, eligible for potential systemic therapy and consideration for further staging as well as molecular analysis of their tumor. So it can be very clinically significant to find or not find microsatellites. They're defined as the presence of a microscopic discontinuous focus of melanoma that's adjacent or deep to a primary melanoma on pathologic exam at the primary tumor site. The tumor cells have to be discontinuous from the primary tumor and separated from the primary tumor by normal stroma. If the tissue in between is fibrotic or inflamed, it's not supposed to indicate a microsatellite because those changes may represent regression in the intervening tumor. And there's no size threshold or distance threshold that the focus needs to be from the primary tumor, which I think is different from previous versions of the tumor synoptic. So that's kind of a lot. I think generally it's recommended, I think, before diagnosing the presence of a microsatellite to get some deeper levels, because you do want to make sure that it's not a focus that got deeper levels would become apparent that it's linked up to the primary tumor. So I think that's one of the more important things. And as I mentioned earlier, with this adnexal involvement, you also want to make sure that whatever you might be seeing in the dermis isn't actually part of linked up to an adnexal structure. So again, deeper sections can help there. And I guess those are the two kind of primary pitfalls that I recognize, other than is there subjectivity in defining what might be fibrotic or inflamed, or there's some kind of like subtle changes there that may be hard to interpret. But
that's true. So the histology should be pristine in between. The stroma in between should be something like clear, pristine, and there's nothing, no changes there, nothing that is kind of tells us that there's kind of a process of regression there that happened before, something that kind of caused this two foci to be disconnected. Yeah, it can be tough.
One of the challenges I've had here in this area is if it's a deep melanoma and the lesion was previously biopsied, partially sampled, there's a lot of inflammatory changes. In that setting, it can be difficult if you've got, tumor cells deep to this previously biopsied inflamed area that are kind of separate from the rest of the tumor. How to sort that out into whether they're microsatellites or just part of the original tumor can be challenging.
And it's interesting. So this will require re-excision. So if the microsatellite lesion was already the margin was negative, the microsatellite lesion was not reaching the margin at the initial excision, it still would require re-excision, right? Because of the mere presence of microsatellite lesion. Is that correct?
I think it, Dr. Shon can correct me if I'm wrong, but I think it would depend on, how big the excision was that you got. I mean, if they, in the margin status of the main melanoma lesion, I mean, if the main melanoma is, a centimeter clear and there's a microsatellite that's, a few millimeters from the margin, I don't know if they would re-excise that or not, or if they would just go on to systemic therapy. I'm not sure.
Dr. Shon?
Yeah, I agree. I mean, yeah, it really depends on case. And then, again, that's why, also depends on the tumor subtype and then, the location of the body. And then also the exact margin status. If it's like, less than, in our practice, melanoma is, regardless if it's microsatellite or not, if it's less than 3 millimeter from the closest margin, clinicians actually at least consider re-excision. And also, it depends on subtype. Some melanomas tends to be skip, right? So really depends, case by case. But I mean, that's why, the WHO proposed this new pathway-based classification.
Thank you, Dr. Shon. So before I proceed with my next question, I would like to congratulate you and your excellent team for putting out this melanoma protocols and being part of the cancer committee before. I know that, as you described earlier, it's a tedious process. This takes a while to have this develop. So I'd like to congratulate you and your team. I would like to mention their names. So in addition to Dr. Shon, we have Dr. Nagarajan, Dr. Frischberg, Dr. Gershenwald, Dr. North, Dr. Prato, Dr. Scollier, Dr. Flotti, Dr. McCalmont, and Dr. Smaller. So again, congratulations, guys, for having the melanoma protocols, and starting with last year and this year, we finally have this melanoma protocols for excision and for biopsy. So my next question is regarding the rest of the elements. And there are other elements there that are required and some elements that are not mandated or required. So Dr. Shon, can you tell us briefly of some of these other elements in the melanoma reporting protocols and their significance?
I guess I'd like to revisit and comment on ulceration, which is as you know, is a key dominant independent prognostic factor in invasive cutaneous melanoma. And again, it's a core component of the current AJCC staging system. I really like to emphasize that only non-traumatic or tumorigenic ulceration should be recorded as ulceration. So, if ulceration is present due to a prior biopsy or any prior procedure, the tumor should not be considered ulcerated for staging purposes. And this is actually very important. I'll say regarding regression, I'd say it's still controversial, and there's a conflicting data out there. Currently, regression is not part of any staging system. So it is optional in our current protocol. However, we have made a minor modification in the most recent release, adding the option to report margin involvement by tumor regression. To me, I think that this is important because the presence of regression at the margin may prompt consideration for re-excision, as it may suggest the possibility of residual melanoma beyond the visual margins.
Thank you, Dr. Shon. Going back to that ulceration, you used the word non-traumatic, right? Versus a traumatic.
Yeah, so non-traumatic, tumorigenic.
Tumor. Okay.
Yeah.
So can you tell us, for the audience, can you tell us the difference between the two and how do you make a distinction? Some practical tips, basically.
Yeah, I mean, so yeah, again, the history is very, very important. Whether it was the prior procedure or prior biopsy is very important. And sometimes very, very hard. And some of the features that the fibrinous exudate presence of the fibrinous exudate and then the underlying tissue response, such as granulation tissue, is the clue for true tumorigenic ulceration. But sometimes really hard. Another point actually I kind of want to make is sometimes you have a tumor with a very large and deep ulcer. And as Dr. Kinonen mentioned, when you measure breast thickness with the ulcerated tumor, you measure from the base of the ulcer. So if you have a very thick, large, deep ulcer, this may actually lead to underestimating actual tumor thickness because you are basically excluding the fibrinous exudate overlying the tumor, right? Which is very rare, but I tell my trainees when we're dealing with those cases, yeah, probably we are underestimating actual tumor thickness, but I think that this relatively small error usually doesn't really affect the prognosis because most of the tumor with a big, large ulcer, they already very thick and they have other high-risk features anyway. So I typically, because of consistency, I usually just tell them to, just follow the protocol and just measure from the base of the ulcer to down. But back to your question, sometimes it's very subjective, and without the appropriate clinical history, then it's very hard. So that's why when you look at our protocol, there's actually option to indeterminate, and then we just I mean. You have to be very honest, and then
exactly.
So sometimes we have to just put the indeterminate without the appropriate clinical history.
Yeah, this indeterminate option in the protocol is it's been discussed a lot, but in many situations it can be helpful, I would say, and we use it often. So I would say that these two melanoma protocols are really truly helpful, beneficial to our practice, to the practice of general surgical pathologists. For the clinicians used, to kind of correlating with the requirements or the pathological factors needed in the guidelines. So with this ongoing advances in the field in melanoma, I have a question this question is for both of you. So what do you think are in the horizon for pathologists in melanoma reporting? I would like to start with you, Dr. Kinonen.
Well, I find predicting the future hard. I guess I would say, as with a lot of other areas of cancer, it seems like molecular classification is evolving, and it seems like that's a good candidate for some area we would see. There's a lot of molecular, diagnostics used in melanoma, especially at academic centers. I would expect that's probably a leading candidate for changes that we may see in the future. I don't have specifics to suggest there, but I guess that's an area that we probably should expect. In general, I guess I would say that in cancer in general and melanoma, I actually think there's a lot more that we don't know than we do know. So I think there could be any number of breakthroughs that just give us some, really important insight into how melanomas, why a certain lesion metastasizes, why another lesion doesn't. I think we know so little about the process really, which isn't to say we don't know a lot, but I just suspect there's a lot more that we don't know. And so I would just say that it could be could be the unpredictable, could come around the corner in 5 or 10 years.
Exactly. There could be enormous change there in the future. We don't know at this point in
Yeah.
time. And for you, Dr. Shon.
I guess I'd like to mention about the TIL, which is one of the components in our protocol, the tumor infiltrating lymphocyte reporting. Historically, there are 3 categories, right? The absent, non-brisk, and brisk TIL. And at least my understanding, the inter-observer reproducibility is actually relatively good, at least in academic center. With the recent development of an AI-based algorithm, especially utilizing digital pathology platform, I believe there will be more comprehensive reporting to evaluate the tumor microenvironment, not just simply, there's absent, non-brisk, and brisk. And especially with advanced immunotherapy, we are living in the immunotherapy era. So speaking of immunotherapy, I think that more and more patients will receive neoadjuvant therapy for advanced melanoma. And as a pathologist, I think that we'll definitely encounter those specimens after neoadjuvant therapy, whether it's the targeted or immunotherapy or combination fashion. I believe the International Neoadjuvant Melanoma Consortium has already developed a reporting template for melanoma, and I think that which could be another actually potential protocol for the skin cancer committee to create or possibly similar to other cancer type incorporate into our current melanoma protocol.
So this tumor infiltrating lymphocytes is also used as a predictive marker for immunotherapy. Is that what you're saying?
Yeah, I mean, we don't know yet, but in the clinical trial setting, that's actually something that not only just like simply, I mean, currently it's optional, and then we just use absent, non-brisk, and brisk. At least my experience during part of the clinical trial, TIL is sometimes very important component, and I think that if you ask me what's in the horizon, I think this is the one thing with the advance of digital pathology. I think this is the one area that maybe we'll do somewhat differently than our current practice.
I'm curious, in terms of doing molecular testing right now for any purpose treatment or diagnostic, roughly what percent of your diagnosis of melanoma you order those molecular testing, Dr. Shon?
I mean, so in our practice, because of our clinician who's probably treat more melanoma than anybody else in Southern California, and then many of our advanced the melanoma patient with the phase 1 clinical trial, pretty much all of our actually our patients are. I'm already done extensive workup, and then they do additional molecular workup. I mean, but they're all stage 4 melanoma patient. Stage 1 or it's not that often they are asking the molecular testing. I see more and more requests. I'm not sure that's kind of your experience, but at least in Southern California, more and more actually dermatologists asking Castle tests for GP gene expression profile classification, which is I don't think we have enough time to talk about it, but it's somewhat controversial area. But that's another thing. It's not required, but I'm getting more and more requests from not the oncologists, but the dermatologists.
That's interesting. And for you, Dr. Kinonen, how often do you order molecular testing, or how often does your clinician order molecular testing for them?
Well, we get for the Castle comment, we do get some dermatologists that ask about that periodically. We're not getting pressed too hard about it, but it does come up sometimes in our practice. So we don't have molecular at the community hospital I'm at. We don't have molecular diagnostics in house. And we've talked about maybe partner with someone that can do it for us. We've elected to just not do it ourselves. And when we do have cases that we think would benefit from molecular classification, we'll send it to an academic center for consultation. And that's kind of how we handle it. And then usually it depends on where we send it. Certain academic centers do molecular analysis more than others. So sometimes all of the cases we send for consultation will get molecular, and in other places, some small percentage will get molecular testing. Overall, I don't know what percentage of melanocytic cases we send. This is pretty small. Since we have 4 dermatopathologists, we can usually handle most stuff in-house, I think, without molecular analysis. So, it's probably pretty low, 1-2% of our cases that we'll send out for assistance, something like that. Maybe it's a little bit higher, but I would say most for better or worse, we handle most things without molecular diagnostics.
Thank you, Dr. Kinonen. And unfortunately, that's all the time we have for today. This is a great conversation. I learned a lot. And thank you both for sharing your expertise and insights regarding the content and use of the melanoma reporting protocols. I'd like to turn this over to you, Becca.
Yes, thank you to Dr. Paner for leading the conversation and to our guests for sharing your insights on melanoma reporting protocols. And I want to thank you all for listening to this CAPcast. You can find links to the CAP's protocols in the show notes, including those mentioned during this episode. If you have questions or comments about any of the protocols, please email cancerprotocols@cap.org. And for more information about the CAP, visit cap.org.